Hey there, welcome back to the Dietitians and Nutrition Support channel. Today we're continuing on that electrolyte series talking about calcium. Calcium is super cool because it's super important to the body, as many of these electrolytes have been that we've talked about over the past few months. So calcium is actually the most common electrolyte that you're going to see in the body, and it's going to be primarily seen stored up in bones, which makes a lot of sense. When we think about calcium, we often think about bone health. About 99% of the calcium in your body is stored up in the hydroxyapatite structure, that mineral structure found in bones, which leaves about 1% of that calcium in your extracellular fluid. So if we're thinking about calcium and we're taking that serum draw, we know that it's really just a small screenshot of the kind of total picture of calcium that we're going to see in the system. I'll also note that calcium levels are typically really well regulated by the body's hormone system. So if you see irregularities in calcium, this is a really bad thing because your body does all that it can to really try and maintain that homeostatic calcium level. So if we're thinking about calcium, it's more than just what's making up a whole bunch of bones and teeth in your system, but it also helps with some other functions, including blood coagulation, neuromuscular transmissions, and also smooth muscle contraction. So calcium is super important, doing a lot of things, particularly for that musculoskeletal system. Something else to note about calcium is that when we see it in our serum, we're going to have it kind of in a few different forms. So you can have about half of the calcium found in the serum that's going to be as a free ionic form, meaning this ionic calcium cation that's not bound to anything. It's just kind of free floating through the serum. The other half of the calcium that you're going to see in a serum draw is going to be calcium that's bound to a protein typically. Oftentimes we see that protein being albumin. So if you're thinking about albumin and you're thinking to yourself, wow, I've had a lot of patients that have had not so great albumin scores, right? What can that do to our calcium status? Well, you can actually have instances in which it looks like a patient has irregular calcium status, but it's actually related to the fact that they have irregular albumin status. So we're going to talk today about the different types of lab values that you can get for calcium, as well as how to calculate a corrected calcium score if your individual has a low albumin. So lots of different things to talk about today. Let's go ahead and pop over to our other screen to get started on those pieces.
All right, so let's start off with a normal range for calcium. We're going to see two typical lab values that are taken in regards to calcium. The first one is total calcium levels. Total calcium levels are typically measuring not only the ionized or free ions of calcium that are seen in the blood serum, but also calcium that is bound to albumin. And we will see a large portion of calcium bound to albumin in the serum. Values for total calcium that we're going to be looking for are going to be somewhere within the 8.5 to about 10.3 milligrams per deciliter value. The second measure that we're going to see for calcium is going to be an ionized calcium value. And the reason why ionized calcium is going to be important is because if you have someone that happens to present with low serum albumin scores, then it's highly likely that you're going to have less calcium being measured as present in the system, because if we typically see calcium binding to albumin and we have low albumin for it to be able to bind to, then it's going to be challenging for us to appropriately evaluate total serum calcium. So for this reason, ionized calcium is often used as a way to evaluate the normal ranges for calcium, and this will just measure the ions of calcium that are in the serum. When we're looking for normal ranges for ionized calcium, we're going to see somewhere between 4.4 to 5.6 milligrams per deciliter. And as per usual, these values may be different depending on the institution that you're working at. Also, something to note, these are adult values, and you might see higher values for infants or children. If we pop to the left side of our screen, we're thinking about hypocalcemia. This is going to be a low concentration of calcium in the system. If we're looking at ionized calcium, that's going to be a score that's probably somewhere within anywhere from a 2.6, which is going to be our severe individuals with hypocalcemia, up into the more mild cases, which is going to be that 3.2 to about 4 range. It's going to be those more mild folks. And if we're looking at total, that's going to be somewhere below that 8.5 milligrams per deciliter range. With hypocalcemia, this is going to typically present as either seizures, tetany, and also hyporeflexia. And of course, long-term instances of hypocalcemia could see decreased bone mineralization content as well. Instances in which we might see hypocalcemia are going to be times of alkalosis, and more typically we're going to see that as respiratory alkalosis as opposed to metabolic alkalosis. We'll also see hypocalcemia in instances of a low vitamin D status. Vitamin D itself is particularly important because it helps with absorption and transport of calcium in the system. So if you have too little vitamin D, it would make sense that you would probably have too little absorption and transport of calcium as well. And kind of along those notes, you'll also see instances of hypoparathyroidism. And the reason why we see hypoparathyroidism kind of coming into play with calcium is parathyroid hormone is necessary for the activation of vitamin D. So if we have reduced activation of vitamin D, then we have less active vitamin D. And if vitamin D is necessary for absorption and transport of calcium, it's kind of a little waterfall effect there. We can also see hypocalcemia present in individuals who have had recent blood transfusions. This can happen because citrate is added to donated blood, which can cause for the calcium to bind within the blood. So when the blood is transfused, it's less available for the individual to be able to utilize it. Kind of along the lines of vitamin D and its use for being able to transport and move calcium through the system, we also see that magnesium is going to be a super important player to being able to particularly transport calcium in and out of cells. So if we have inadequate magnesium, it's definitely going to be challenging for us to get calcium to the places it needs to be. We can also see hypocalcemia presenting in individuals with renal insufficiency, individuals with sepsis, and individuals on certain medications. Some common medications that might cause this include proton pump inhibitors as well as aminoglycosides. If we're looking at treatment and management of hypocalcemia, we first have a choice of oral supplementation, oral or enteral supplementation. We're typically going to want to provide anywhere from 1,000 to about 1,500 milligrams of calcium in a day, but oftentimes we want it in about a 500 milligram dose. So this is going to lead to anywhere from 2 to 3 times per day that you might provide that. And if we're looking at options here, we typically see folks getting calcium carbonate as it has the highest amount of elemental calcium. And this is for the most part absorbed in the small intestine. If we're looking at IV provisions of calcium, we're typically going to see someone provided mostly if they're symptomatic hypocalcemia, so they're experiencing the seizures or tetany, something in that regards, and we'll typically see that IV source being calcium chloride or calcium gluconate. For the most part, people typically prefer calcium gluconate as it's the most stable in solution. In parenteral nutrition, we're going to provide anywhere from 10 to 15 milliequivalents of calcium per day. So this is not a per volume amount, but actually a per day amount. And note that we've had kind of some special indications before for other electrolytes, but calcium, phosphorus, and mag are all going to need to be kind of balanced mindfully within our parenteral nutrition solution to ensure that we don't create any precipitate, because we obviously don't want to infuse that. And this can also depend on the amino acid and lipid content of the base formula as well. So just keeping in mind that anytime we're going to be doing IV calcium, we'll want to be aware of precipitates. If we pop to the other side of our screen here with hypercalcemia, that's going to be instances in which we have excess calcium in the serum. So if we're looking at our total values, we're going to be looking somewhere above the 10.3 milligrams per deciliter range. And if we're looking at that ionized, that's going to be somewhere above that 5.6. For the most part, hypercalcemia is pretty uncommon, presenting in less than 1% of hospitalized patients. But if it is presenting, it'll often show up as nausea or vomiting, oftentimes as constipation as well. Sometimes this can cause an ileus, hypovolemia. Sometimes it can lead to hypotension, confusion, or a general decreased mental status, and in some very severe instances, coma. Now for hypercalcemia, it's a little more clear for most cases how this kind of results. For about 90% of cases, we're seeing that being caused by hyperparathyroidism. And malignancy. Again, as we kind of talked about earlier, if you are having excess parathyroid hormone, it would kind of be the opposite of this side of the table, in which we didn't have enough activation of vitamin D and didn't have enough movement of calcium into the system. But if you have excess parathyroid hormone, that can lead to excess vitamin D activation and excess calcium release and movement in the system. So any kind of irregulation, dysregulation within that system can be kind of challenging for calcium status. We can also see other instances of hypercalcemia happening from prolonged immobilization, from very excess vitamin D, and particularly vitamin D intoxication, from acute renal failure, and particularly that so with rhabdomyolysis, and also instances from very excessive calcium carbonate intake. And that's often from instances in which people are consuming like a whole bunch of antacids. So if we're looking at treatment for hypercalcemia, it's probably pretty clear that our first step here is going to be removal of exogenous calcium. So if you have someone who is always eating antacids, we probably need to remove that. If they are for some reason like chugging milk and getting just so much extra calcium, more than their body can handle, even though I don't think that that's really a common instance, we just want to kind of start to reduce that excess exogenous calcium. So the second category of treatment and management that we'll see here is going to be medication usage. So the first one you might see is a saline infusion with some kind of a loop diuretic. So the diuretic is going to cause for more fluid loss, and this often leads to excess electrolyte loss as well, and this can help to kind of increase calcium wasting, so it's not going to be calcium sparing, you're going to be excreting more calcium if you're on a loop diuretic. The next thing you might see is treatment with calcitonin. So if you are treating with calcitonin, it can actually help to reduce kidney resorption. So again, kind of allowing for more of that calcium to be excreted through the kidneys. And finally, you might see treatments with a bisphosphonate. And these are particularly important because they help to kind of prevent bone breakdown. So it's going to reduce the amount of calcium that is liberated from bones. So that will help reduce the amount that's contributing to the serum and into the system. So we've gotten a chance to hear a little bit about hypo and hypercalcemia, but one last piece to this video, we wanted to take some time today to talk about corrected calcium calculations. All right, so let's think about this idea of corrected calcium. So as I kind of mentioned earlier, if we're looking at a total calcium measurement, we're going to be measuring not only the ions of calcium that are kind of floating through the serum, but also calcium that's bound to albumin. So if you have a patient that presents with low albumin, it's more than likely that they're also going to present with a lower calcium score as well, because there's less albumin available for the calcium to bind to. So this is not a super great thing because it can sometimes lead us to thinking that a patient has calcium issues when really it's an albumin problem. So to be able to identify whether or not albumin is actually impacting our patient's calcium status, we can do a corrected calcium calculation. So the equation that we're going to use for corrected serum calcium is going to be talking about kind of a standard albumin value of 4 grams per deciliter. And then we're going to subtract from that what our individual's serum albumin is. So whatever value you get for serum albumin. We're then going to multiply that by 0.8. Once we've done all that math to find kind of our serum albumin score, multiplied it times 0.8, we're then going to add the serum calcium score that we got. So by being able to kind of normalize based off of the albumin that's available, we can then interpret whether or not our individual has inadequate calcium as well. So let's do a quick example. We're going to first start off with our 4.0 grams per deciliter, and we're going to subtract that serum albumin score. The example I've provided for you today, we're saying is 2.5 grams per deciliter. Okay, so we've got that value, and then we're going to get to multiply that value by our kind of standard number, 0.8. That helps to complete our brackets. And then we're going to add on to the end of that our serum calcium value, which is 7.5. If we remember our total calcium reference range, we were actually looking to be somewhere between 8.5 to 10.3, so this serum calcium would present as a hypocalcemia instance. Now, if you were to solve all of this through, you would be able to find out that we're actually getting a corrected total calcium that's equivalent to 8.7. So when we see this 8.7 milligrams per deciliter, we know that our previous measurement of 7.5 was decreased because we had such a low serum albumin score. And if we correct it based on the albumin that was actually available, then we can see that our corrected calcium score would actually be an 8.7, which brings that person up into the normal range for our total calcium kind of goal range. So this is just one way in which you can more accurately utilize total calcium evaluations, particularly for those individuals who have low albumin scores. So let's go ahead and pop back to the other screen and we can wrap this up.
So at this point, we've had the opportunity to talk about hypocalcemia and hypercalcemia, as well as various different types of lab values that you might see for calcium status. You have all the tools you need to calculate a corrected calcium value, which could be super useful to you, particularly if you have a patient who has irregular serum albumin levels as well. And hopefully all of those pieces can fit together to help you feel confident in the way that you might manage calcium in your future patients. If you have any questions or comments, please feel free to leave them in the comments boxes below, and we look forward to seeing you next time.